Thank you very much, and thanks to the organizers of this meeting for inviting me to speak, and thanks to you for being here on such a lovely day outside. And I am going to talk about a few clinical trials and the overall impact of clinical trials on gastric cancer. So the take-home message that I'd like for you to know is that with clinical trials in gastric cancer, there is improved survival. So thank you, and if you will join with me.
The big green one. The big green
Got
one,
it.
yeah.
So if we look at the trends in cancer over a long period of time, and these are data reported from the American Cancer Society, what we see in men, there has been a tremendous decline in death rates over the years. That's gastric cancer or stomach cancer in the yellow line, and note that yellow line has decreased significantly over the last few years, and this is reported for men and the same for women. So we've seen a significant decline in stomach cancer death rates over the last few years. And if we look at all of the solid tumors, note that the decline in stomach cancer has been more significant than for most other cancers. And this is really for a number of reasons. Number one, the manner that we process foods has contributed to a decline in the number of cancers that we see, but also we have better surgical management, better post-op management of the surgical patient. We've got a better understanding of the pathology, so that has contributed. Now we have the various markers and new drugs that have been approved for treatment of stomach cancer. So there are multiple factors that have contributed to the decline in death rates from stomach cancer. And very importantly, clinical trials and the patients and their families, the patients who participate in these trials. So I'll go over some of the understanding that has allowed us to be more specific about our treatment of stomach cancer. And we are almost to the point where we can say personalized medicine in terms of treating stomach cancer. So for esophageal and gastroesophageal cancers versus gastric cancers, if one looks at our clinical trials, what you will find is that if you're studying the trials of esophageal cancer, there will be some GE junction, meaning where the stomach meets the esophagus, included. If you look at stomach cancer trials, you're going to find that GE junction are part of the esophagus, a part of stomach cancer trials. So really understanding these and putting it all together, especially in the overlapping tumors, has contributed to our understanding, and that's a part of the clinical trials. This was included in a new staging of the trials, and basically that new classification really allows us to understand the tumors, the location of the tumors, but more importantly, to bring together the understanding that the lymph nodes in stomach cancer are very important, and that has contributed to our understanding. You will find that in the surgical trials, the lymph node reporting is very important. So understanding and bringing something together on these esophageal gastric tumors, and then the combination of the GE junction in the tumors. With our new understanding, you've heard this morning about the surgery, you've heard about genomics, and that is related to the fact that there are certain markers that may be more important in areas of the stomach that are related to cancer development. For example, H. pylori, which is an infection, might affect cancer growth in certain areas of the stomach and perhaps not in others. So understanding the risk factors and the location of the tumor, as well as those drivers of the molecular understanding and molecular proliferation and growth of the tumor. For early stage gastric cancer, there have been many clinical trials over the years, and I won't spend a lot of time on them, but understanding how an agent or a procedure affects the tumor, very important. Whether we give that agent before surgery, whether it affects the surgical approach, or whether it's given after surgery. So there are a number of agents that have affected overall clinical trials and the importance of the tumor at various stages. So optimal adjuvant therapy for gastric cancer in the United States, basically 2 or 3 drug combinations preferred. There are the alternatives, ECF, such as the MAGIC trial you've heard about earlier. Capecitabine with oxaliplatin is another way. And in Japan, where tumors may be somewhat different, that has been shown to be a standard treatment. For first-line treatment, single agents, there have been a number of studies over the years. You've heard some of these drugs mentioned earlier, but clinical trials demonstrating the effectiveness of these drugs, paclitaxel, docetaxel, irinotecan, vinorelbine, and others. So clinical trials have demonstrated the effectiveness of some single agents, as well as various regimen for first-line treatment of gastric cancer, such as you've heard of FOLFOX, irinotecan plus oxaliplatin, and so forth. So there are trials that have demonstrated the efficacy in first-line as well as second-line treatments. So this is just one example of ECF and others that was conducted in Europe. And what this showed was that the EOX combination was slightly superior to the ECF combination. And therefore, that's how this became a prominent use. An example of second-line therapy for metastatic disease, docetaxel has been approved in this dose, but irinotecan, another, and a higher dose of docetaxel. So you may find differences in the chemotherapy regimen, but most have been tested and have gone through clinical trials. In understanding the pathways that support the growth of stomach cancers, there are a number. EGFR are the human epidermal growth factor. There's also vascular epidermal growth factor, CMET, fibroblast growth factor, and others that I will cover later. And in understanding how these all work together, if you imagine a cell has a number of pathways, and those pathways crosstalk. I tell my patients that cancer cells are really smart. They talk to each other. You block one pathway, they figure out, talk to another pathway, and the other pathway becomes activated. So there are multiple areas where pathways speak with each other. And what I want you to focus on is the outer rim of that ball, the ball meaning the cancer cell, and the outer rim. So there's VEGF, HER2, epidermal growth factor, CMET, and others, and we'll spend a little bit of time on those pathways. So there are antibodies and tyrosine kinase inhibitors that block various areas. You've got HER1, HER2, HER3, HER4. So they're basically, when we refer to HER or HER, there are 4 of them that are in the family. They can either, and in order to affect cancer growth, they have to join together. So they can join together as 2 of the same, so there can be two HER1 or two HER2, or they can join with different ones, so there can be a HER1 plus a HER3, but they work effectively, as I say, married. So for activation, we have to have the joining, and you will see in some of the studies that I show you. So basically, they inhibit by dimerization, and dimerization is simply joining together. So a HER1 with a HER3, two HER1s together, etc. And what that does is allow for blocking of those pathways that result in cancer growth, cancer cell differentiation, and cancer cell metastases. This is an example of the EXPAND trial, which is blocking HER2. Basically, two chemotherapies, capecitabine, cisplatin, plus cetuximab, which is the agent that blocks HER2. There's epirubicin, oxaliplatin, capecitabine with panitumumab, another drug. And I also want to emphasize that we should not get so excited about clinical trials before they end. And that is because many times we think that it's going to be real great, but what I tell everybody, don't get so excited until the clinical trial ends. In other words, show me the data. And having spent many years in Missouri, the show me state, I say, let's wait, you gotta show me. So in this trial, we were very excited about panitumumab, and it may have had a detrimental effect. So again, show me. This is the HER2 pathway in gastric cancer, and note that trastuzumab, TDM1 are the agents that block that area. So these trials, the TOGA trial with 5-FU and capecitabine plus cisplatin plus or minus trastuzumab, and note in the red block that the results of this trial showed that chemotherapy given with trastuzumab had a greater benefit than chemotherapy without trastuzumab. So therefore, benefit from this trial, and consequently, that has become a standard in testing gastric cancer. Now note the X's. The X's here are blocking two things, EGFR and HER2. And here, this is an agent, Lapatinib, that has been used in breast cancer and has tremendous value in breast cancer, but since it inhibits these two, it was therefore tested in stomach cancer. So inhibiting that, and note that the results of the trial, chemotherapy plus or minus Lapatinib, the group in the red block treated with Lapatinib had improved benefit. The Titan trial used paclitaxel. Paclitaxel, an agent that we use in gastric cancer, with Lapatinib as second-line treatment of gastric cancer. And again, Lapatinib showing just slightly improved benefit in this trial. There's inhibiting dimerization. I mentioned that you have agents, you've got HER1, HER2, and so forth. You can prevent the marriage. So preventing the grouping together or the marriage of those, and that agent is called pertuzumab. And in the pertuzumab trial, chemotherapy with or without the agent, and it is comparing the TDM1 versus a taxane, and the anticipated completion 2015. So this clinical trial has been completed and data are expected. Angiogenesis inhibitors in gastric cancer. Angiogenesis means the growth of blood vessels. In order for tumors to grow, they must develop blood vessels. And there are agents that inhibit the growth of blood vessels. Bevacizumab inhibits VEGF-A, note on the right side of the screen. Bevacizumab has been utilized in colon cancer as well as many others, and it can also inhibit the growth of the tumors. So in this trial, it was cisplatin with capecitabine plus or minus bevacizumab, which inhibits the growth of the cancer. And this study has been completed and therefore did not show significant benefit, although this was a trial that everybody was excited about. And note that it showed very little benefit in gastric cancer. Sunitinib, some know it as Sutent, approved for other cancers in the United States, but it too has been utilized with chemotherapy. This was another agent, sorafenib, and that has been completed. It is an angiogenesis or blood vessel agent. So targeting VEGF receptor 2, we can either target the growth factors for blood vessels in the bloodstream, as bevacizumab does, or right at the cancer cell site. Notice on the red on the right side of your screen for VEGFR2. And ramucirumab is the agent that inhibits the receptor. Ramucirumab, this is a clinical trial for patients who had received other therapies, and they were randomized to receive ramucirumab or placebo. And that study was positive in that the patients receiving ramucirumab had improved overall survival, and therefore this was approved. So the REGARD trial, another choice after progression. So we have ramucirumab. So the RAINBOW trial looked at ramucirumab versus paclitaxel and comparing to paclitaxel, which is chemotherapy. So this was the trial, paclitaxel or ramucirumab, and therefore ramucirumab plus paclitaxel had greater benefit than chemotherapy alone. So adding the ramucirumab to the paclitaxel. Another study is still being evaluated, the data, with first-line treatment of stomach cancer, adding Folfox, which is a standard, versus Folfox with ramucirumab. So that trial has been completed and understanding it ongoing. One trial that I want to bring to your attention that is ongoing, and that is the combination of capecitabine with ramucirumab. It's a study of ramucirumab and cisplatin to participants with stomach cancer. It's called the RAINFALL. This is a first-line metastatic disease trial, and it will measure progression-free survival, so an ongoing study. Another study that was just reported earlier this year with another agent, it's called the Integrate trial, and this was a randomized phase 2 double-blinded study with regorafenib, which is another angiogenesis agent, and chemotherapy. This trial was reported, and there was significant improvement with the angiogenesis or the blood vessel agent. Consequently, a phase 3 trial is being planned at this time, and we hope will be open later. So regorafenib, another anti-angiogenic agent undergoing study. Now, there are other markers that we had talked about, the MET inhibitors, and note the MET inhibitors are in the orange on our cancer cell, and for MET markers, that influences growth of tumors, and there are therefore MET. MET means mesenchymal epithelial transition factor. So it too can influence growth of the cancer cell by affecting those growth and proliferation pathways. There are studies ongoing with MET inhibitors. There are a number of these MET inhibitors that are in clinical trials now and ongoing. What we don't understand, however, is having that MET receptor on the cancer cell, whether that affects the effectiveness of the treatment and the various agents. So a number of these MET inhibitors in clinical trials. This is simply one. It's called rilotuximab, and Rilotumumab in gastric cancer. There is it's first-line treatment of unresectable locally advanced gastric cancer, and we were able to understand, or at least measure, the MET on the cancer cell to compare that to Rilotumumab. There is another study with FOLFOX and Onatuzumab. So again, this is a MET. There are the hedgehog inhibitors. This is another group, and we don't understand how the agents that inhibit hedgehog work. However, hedgehog is a very important marker in gastric cancer that can affect growth. So the progression-free survival of this study, although we were very excited about it, showed no improvement in the patient management. So again, we have to say, show me. There's immuno-oncology and checkpoint inhibitors. The anti-PD-L1 agents, there are a number of them in clinical trials, and I'll explain further. So checkpoint inhibitors are immuno-oncology. This is different from the vaccine. So for immunocheckpoints, what this means, in the green cell, that is the T cell. And the T cell is in the blood, that is part of the immune system, and it helps fight against infections as well as tumors. So revving up these T cells to help one's body fight the cancer better is a method. So there are various methodologies for stimulating and enhancing the function of these T cells, and as they increase, then they are, the effectiveness is measured. So this is a study. It's a study of pembrolizumab, which is one of the agents with recurrent metastatic gastric cancer or gastroesophageal junction adenocarcinoma. It's a phase 2 study. It recently opened and is on clinicaltrials.gov. The primary outcome of this study is to evaluate the side effects, the effectiveness in shrinking tumors, that is the overall response rate. So you'll see ORR on a lot of the studies. That's overall response rate and the number of patients that experience shrinkage. So that study is ongoing. And if we look at the number of trials that are open now, I can't go through all of them today, but a number of these receptors that I've mentioned, the HER1, 2, 3, and 4, the MET trials, and you will see them as either MET or CMET. There's the VEGF-RC or VEGF receptor. There's mTOR and a number of these. So these are targeting those receptors that I indicated previously on cancer cells. So trying to inhibit the growth by inhibiting the function of those receptors. So when we look at the various immunotherapy trials ongoing, they're the PD-1, anti-PD-1. Most of these are in phase 1 studies at this time. Some are ongoing to phase 2. So a number of these trials ongoing, not only in stomach cancer, but many other cancers as well. So if we summarize clinical trials in stomach cancer, first we can say there's improved survival. There is improved survival in patients, and our understanding of how these cancer cells grow has allowed us to therefore develop specific agents that target those receptors that promote growth and proliferation and consequently metastases. So if we look at just the overall approach to gastric cancer, first of all, there is poor survival if we look at just surgery alone. There's adjuvant therapy in the cancers. We can either give pre-op therapy, peri-op therapy, or we can give post-op adjuvant therapy. and therefore these clinical trials have demonstrated the effectiveness and benefits of all of these. For treatment of patients with metastatic disease, we can think of 2 or 3 drug regimen in this country and good response rates in all. There is the basic chemotherapy, oxaliplatin-based therapy, or paclitaxel, the Taxols, irinotecan, and the addition of the targeted therapies or comparison in many cases of targeted therapy to the effectiveness of the standard chemotherapy. For targeted therapies, it has been demonstrated that trastuzumab, which inhibits HER2, is very important. There are other agents coming down the pike. I showed you the trial with Lapatinib and others. And then immunotherapy. These trials with immunotherapy should be considered early trials, and we don't know the impact or effectiveness of all of the immunotherapy trials in the treatment of stomach cancer. So with that, I thank you for your attention. I'm happy to answer any questions.
Thank you very much. Really nice. I know that's a lot of information, very scientific for all. Does anybody have any questions regarding clinical trials? We have one here, if you can bring the mic to the front, and we'll start here in the front. We'll start here. She's got the mic. I'll take this one. Thank you.
Dr. Mitchell, do you know of any clinical trials for CDH1?
There are some trials ongoing with CDH1. That's another of the agents. They are listed on clinicaltrials.gov. I do not have one at my own institution at this time, but they are listed. And understand that with the phase 1 trials, they will open and add a few patients and then close. So, and that closure is to evaluate the toxicities and the effects on the patients. So they may open and close with varying intervals.
The reason I asked it, the tumor results that I got back, it listed CDH1, but it said no clinical trials at that time, and they gave no targeted drug for CDH1. So I was surprised.
Yes,
there were
there's
5 others, but for CDH1 there was none.
Sure. So understand that when your tumor is sent to these agencies, and I have patients come in for a consultation, and the agency sends back 40 different markers. That information is there, but for most of those, we don't know the effect of those markers or whether inhibiting the marker can result in patient information. Now, there is a trial that is going to open later this year, or it is anticipated. It's a National Cancer Institute trial. And what happens is, instead of getting a paper with all of the markers and so forth, and we don't know what to do with it, you will send, or your doctor will send your tumor to the National Cancer Institute. It will identify which markers are prominent in the tumor, and then match it with medication and tell your doctor how they may obtain that medication. So it will simplify the process. This clinical trial is called the MATCH trial, M-A-T-C-H. The MATCH trial is a National Cancer Institute trial, and it is expected to open later this year. And we hope that will solve some of the problem of getting this paper with a long list of markers, and we don't know what to do with them. And therefore, the trial, the match part of it, will match drugs with the marker. So look out for that.
Yeah.
What I got back from my tour did that, but they just didn't have a match for CDH1.
Right.
But it was beautifully done in report.
It's a very nice report,
Yeah.
but for most of us in clinical medicine, we have no idea what to do with it. So I'm really excited about the MATCH trial that will be coming along, and hopefully, and it will be for multiple tumor types. It's not just for one tumor type. So this will help us.
Yeah. Thank you.
Or we anticipate, but again, the results of the MATCH trial, for me, as I say, from Missouri, you got to show me.
Thank you. Our panelist in this section on clinical trials is also Dr. Elson, and I'm going to ask him for what his impression is of the MATCH trial.
Yeah, I think, because not all patients have access to particular centers, and for geographic issues, also some insurance will not cover genomic profiling of tumors because it really is not yet standard of care. So I think it allows practitioners that have fit patients that are motivated and considering access to novel therapies across a whole spectrum of cancers to do a centralized testing through the NCI, and I think it's going to be a promising mechanism. Some individual centers have their own sort of what we call basket trials, where you have a trial that targets the mutation but not the cancer. So I think the MATCH trial is going to complement efforts that are ongoing at many centers. And because the caveat is just because you have the mutation doesn't mean the drug is going to work, because every cancer's biology is different, every tissue type is different, and but that's what, we're hopefully will move the field forward with a real focused approach, and you don't know if you're going to succeed unless you try.
Great, thank you. We have some more questions here. It's on early detection in gastric cancer. There's no question mark blood markers or biomarkers, and the question is why?
So biomarkers in gastric cancer, I've mentioned some of the ones that are on cancer cells and that we are studying. We don't have a blood marker at this time to give us ideas, but ongoing studies are utilizing what we call circulating tumor cells, or CTCs. And based on the fact that if the cancer is in the stomach and it later spreads to the liver or to the lungs or other organs, it usually goes by, or we assume, through the blood. So therefore, evaluating the blood for circulating tumor cells is an area of research, but at this time cannot be considered the standard of care. So lots of research ongoing to try and identify blood markers. We're just not there at this time. But I encourage participation in these trials and try not to become too overexcited that this is the real answer and we're going to cure stomach cancer based on one trial. We have to look at the results. But there's ongoing research on use of blood markers and CTCs. So some institutions may have clinical trials ongoing where they will take a sample of blood, measure the circulating tumor cells, and the idea is, number one, to compare circulating tumor cells to see how they compare to the tumor and whether or not that might be useful in the future. There are actually companies now, unfortunately, advertising them as liquid biopsies. And at this time, it has not been shown that this is absolutely the way to go, or what the role of these circulating tumor cells will be in stomach cancer as well as other cancers. They've been shown to have some effect in cancers such as prostate and colon and breast cancer, where there are large numbers of circulating tumor cells. But those three cancers are the only ones where there's proven benefit at this time.
We have a question for Dr. Ilsen here. Is Asia, do they have better screening and that's why they have better survival? And in colon, you get a colonoscopy every 5 years, so why not in gastric cancer where you can get an EUS every 5 years?
Well, they screen in Asia because gastric cancer is the most common cancer in Japan. So it's cost effective. Colon cancer is also common in Japan. Unfortunately, we just can't screen the entire population of the U.S. for rare cancers. It's just not economically feasible. So we do colonoscopies, we screen for breast cancer, we screen for colon cancer. There's a debate about screening for prostate cancer where we actually have a blood marker, we have PSA. But for rare cancers, it's just not feasible. I mean, it's just, I mean, our healthcare system now is sort of at the breaking point with costs, and it's really not, unfortunately, not the type of screening that we could incorporate routinely because the incidence of the cancer is relatively rare. So countries that have this cancer as the number 1 or number 2 cancer do screening, and outcomes are better also because of biology of the cancer. Actually, if you look at the number of cancers in Japan that are found with screening, it's only about 10% of gastric cancer. So even though they screen in Japan and they do find earlier stage cancers, it's not like the majority of gastric cancer in Japan is found with screening. Unfortunately, we have to, with rare cancers, we can't propose screening to the general population because it's just not economically feasible to do. Even with a colonoscopy, it's positive 2% of the time. And yet, even with colonoscopy, with rare cancers, only about 60% of the population avails themselves for colonoscopy. In terms of biomarkers for screening for other cancer, we're making progress, like instead of doing a colonoscopy, screening the stool for DNA related to tumors. That's a promising technology. But a lot of our screening now is quite crude. It involves physically inserting a scope and looking at the colon and the stomach, doing mammograms. So our screening is quite cumbersome and quite crude. But a lot of it's just, unfortunately, just the economics of healthcare, that we just can't propose to screen for every cancer because we just, the healthcare system just couldn't absorb the cost of it.
Well, let me also add, I think it's not just economics. I think there's an important biologic difference. Colon cancers overwhelmingly start in a polyp, which is a precursor that you could see for years before you have the cancer. So that's why they could do colonoscopies every 10 years, because you could see those precancerous growths and take them out. Gastric cancers don't start in that kind of polyps. And so really, if you were to effectively try to screen people, you might need to screen them every 6 months or something to catch them at that window. And even if you look, for example, at people with Barrett's esophagus, which is a precursor for esophageal adenocarcinoma, very similar to gastric cancer, there's been a lot of efforts to do annual endoscopic screening in those high-risk patients, and even in that high-risk population, it hasn't proven effective, has not.
And
so, and if you imagine, $1,000 endoscopy times 100 million adults in this country, are we going to spend, $100 billion a year on annual endoscopies where we don't know necessarily that's even going to improve the mortality? I think you might have anecdotes, but you also might have anecdotes of every time you get a headache, you go to the ER and get a CAT scan. You might find 1 in a million people who get saved, but then at some point you have to, I think right now, and if anything, if you look broadly in the screening world, many things we thought were effective, PSA mammograms, we're sort of increasingly backing off because we're getting a sense that we're actually, more often identifying indolent cancers that may never have caused problems, and not, and not so much actually preventing lethal cancers. I think it's a great idea, but if we have to be careful before we leap into that.
And there's also more to differences in various populations. There's more than just the screening. We have to also remember that there are some risks to procedures, and that may be different. But also, if you look at effectiveness of drugs, you will find that, for example, the effectiveness of a drug in Japan may be very different from the United States or Western cultures. Metabolism may be very different, and how the body handles certain drugs. So there are a lot of differences between populations, and we're seeing that as the United States becomes more of a cosmopolitan society, where we have stomach cancer in a number of Western Asian countries, Western European, and there are differences in drug metabolism, as well as perhaps some differences in the heterogeneity of the tumors. So a lot that we don't understand at this time.
Great, thank you. Are any of you familiar with or have heard of MLN? That's the Millennium's Agent 0264 trial.
I don't know about it.
It's a phase 2 trial against guanylyl cyclase, patients
yes.
who express that. The trial started in January of this year, and it's open.
Yeah, it's a phase 2 trial. This is a target that may be overexpressed.
GCC, yes.
Yeah, in about 20 or 30% of cancers. It's a work in progress. We just don't know. It's a phase 2 trial. I think it actually is fairly unrestricted for patients in terms of prior therapies. So, and I think our center is actually participating in that trial also. I think the Dana-Farber group is also.
Yeah, so GCC is a marker. It was actually described at my institution first. And this is a marker that is on the luminal side of the colon. And you don't find it anyplace else in the body. So that if there's a colon cancer that expresses GCC and it metastasizes, the only way that it could have, that GCC could become positive is for a metastasis. So there have been attempts to devise drugs against GCC. And I know it as GCC. We don't even say it as guanylyl cyclase anymore. But that's what that's all about.
So that trial is actually open at Moffitt. It's open in 2 cohorts, one for upper GI gastric and pancreatic cancer. And like Dr. Yeltsin said, you have to express GCC to be eligible. So this is biomarker driven. And right now, I think it's on hold for some reason because the Million is some kind of interim analysis. But that trial is open at Moffitt. So if any of your interest, it is available.
Okay, great, thanks.
Yeah, and you have to worry about, remember I said some of these markers are not necessarily tumor markers, but if they're in normal tissue. And since there's normal GCC on the luminal side of the colon, that's a concern for these drugs.
Okay, I have another question here. What are your thoughts about, remember there's a breath test that came out of Israel, I think. Do you think the panel, that it's possible with this panel?
For the breath test?
Yeah, for the breast test.
So the breath test, there have been a number of breath tests ongoing to try and have a patient, basically what you do is breathe into a bag and they use your breath for analysis. I have not seen any data substantiating the effectiveness, but the studies continue.
Yeah.
And that's because when you breathe off your breath, it reflects the things that are in your body. And there are a number of different conditions that can be utilized in this type method. I am not aware of any benefit that has been demonstrated at this point in terms of cancer-related issues.
Dr. Ilsen, does stomach cancer normally start in the stomach, or does it normally result as a metastasis from other organs first, such as the spread from the liver, pancreas, et cetera?
No, I think stomach cancers start in the stomach. They start in the glandular tissue that lines the stomach. There are occasional tumor types that metastasize to the stomach. A good example would be breast cancer. Sometimes breast cancers can actually metastasize to the stomach and masquerade like stomach cancer. But stomach cancers start in the stomach. If something metastasized from somewhere else, then it's the tissue of origin where it came from. So, but there are rare cases that breast cancer does metastasize to the stomach. It usually kind of diffusely infiltrates the wall of the stomach. Women have usually had a history of breast cancer. It's usually lobular breast cancer. And the pathologist has to really, in that history, in that presentation, the pathologist really has to make sure that they compare the tissues and do careful analysis. But I've seen one case in 20 years of a breast cancer that went to the stomach, so it's pretty uncommon. But stomach cancers start in the stomach.
Thank you. Well, thank you very much, Dr. Mitchell and Dr. Ilsen, for that presentation. Thank you very much.